and you've got plenty of other things you could do as a practitioner. So to me, because of that extra effort, it really has to be worthwhile. You have to be convinced that it's actually going to make a difference to the patient, preferably by getting their health, improving their overall health. But also it's got to benefit the health system, hopefully by keeping people out of hospital, the ER and stuff like that. So I'm always curious when I come to visit other people who are using the Flinders program to find out, I know you won't tell me really what you think, exactly, but in general terms, like what difference does it make over and above what you would normally do in your practice, I suppose. And because we're all dealing with different groups of patients, we're talking about rural patients who come from a mining community, who've got a whole bunch of chronic diseases, and I'm working with people in Adelaide and Australia with mental health problems. So, what are the differences? I'm really interested in differences or similarities in what we see with someone we were talking this morning about a patient with schizophrenia smoking a lot. And does using the Flinders tools help someone like that? Or does it also help someone who comes from Afghanistan, who's a refugee and can't speak English properly? And I had some feedback from a guy working with the Flinders tools in San Francisco. And he trained as Flinders, and then he trained peer workers, in other words, Afghani refugees who didn't have dementia, to work with people who did have dementia. And they use the Flinders tools to help people with dementia make some gains. So I was pretty shocked to hear that the guy had done that. And I don't know whether you'd seen were you using the new version of the Flinders tools, the My Health Story, the Aboriginal colour version of it, or using the standard tools?
We use standard tools, but some of us are able to look at the video
and the other one. Yeah.
And the representation of that tool.
Okay. So
it's a standard manual.
Yeah. So if you don't know what I'm talking about, we were funded by the Australian government to adapt the whole Flinders program for working with Aboriginal people. And so what that ended up being was a booklet, and a properly produced glossy booklet, and had lots of graphics in it. The language is simplified a bit, but it added on a couple of other components at the beginning of the normal Flinders process, which is like, tell us about your family, your community, people important in your life. So there's one page that had graphics around that, and the practitioner would sit and have that conversation and write down who are the key important people. And the next page was, what are your strengths? What are your interests? What are the things that keep you well? So there's a whole page on that. And then you went into the Flinders tools. So we did that, applied that across Australia, and 6,800 Aboriginal people had a care plan. And we're able to document that after the care plan they had nearly 60,000 occasions of service related to the care plan afterwards. So there's this huge uptake because basically we'd adapted it to be user-friendly. And one of the differences for me was, because this booklet was deliberately produced, that it opened up in a page like that, and the idea was you'd sit together as a practitioner and a patient, and it really forced you to be collaborative. And so you got this one booklet, the two of you prepared to do that together. So what it turned out was, the guy in San Francisco had found this tool for Aboriginal people, and he said because it had all these graphics and very simple, that made it usable for Afghani refugees who couldn't speak English. So I was like, oh, wow, that's a huge surprise to me. Thinking here, and you can imagine it's actually on this graphic thing, it's actually got kangaroos on it, and other things that are very pertinent to an Aboriginal culture, and other things like that. But he said, we ignored that. There were the other colours and the other things about it that made it, just the look of it, actually, that was the big thing I learned. We had a national committee of 14 people to come up with one design for this booklet. The colours, the way the tree was drawn and everything. And you can imagine that in Australia there's 300 different tribal groups, and some of them hate each other. you know, in the Aboriginal groups. And if you would have thought, if you said to a group of people, oh, here's a tool we've adapted for Aboriginal people, the first thing they say is, you know, if you're talking to someone in the Northern Territory, they say, which Aboriginal people? And if you say, such and such a group from somewhere else, they just immediately look at you and say, no, we want the original. So what we were worried was we're going to have to build, you know, 30 different versions, but it turned out this one version's enough. But what really the lesson for us was that the colours, the graphics and everything made it so appealing for the practitioners, I mean, as well as the patients. So in other words, the product had to appeal to the practitioner before it appealed to the people who wanted to use it. So it was like, you know, so we had if you're talking about from a marketing production point of view, the initial customer, if you like, was the practitioner, not the patient. So if you think, if you can adapt a set of tools that, you know, designed in their normal, you know, black and white boxes with numbers in them, but you can stick to the same language and the same concepts with 7 principles of self-management underpinning it, and you then can apply that in all sorts of ways. And I think I was explaining to Mark that the university is now producing an electronic or a web-based version of the Flinders tools, which is going to be called FlindCare, FlindCare, and it's being piloted at the moment in Lehigh Valley Hospital Network. And for those of you who've been using the Flinders tools and that, which you showed me this morning, that paper version with the pieces of paper and everything, the idea, or the feedback we've been getting is that the practitioners who are used to using the Flinders tools in the paper version, they've said they'll never go back to using the paper version again. And it's because it automates the process. You don't need lots of paper. And it automatically sort of populates as you go, typing things in and putting numbers in, it automatically populates a care plan, and if the score's wider than 3 on that, between the cure and response and the partisan health, it'll automatically put that issue on the care plan. You can do manual or you can do automatic and that sort of thing. So based on the feedback from that, the web-based version pilot, we're now going to rebuild the whole thing with lots of other components. But what I meant by the web-based version is the idea is, and particularly I was thinking of in a rural setting, as long as you've got good internet, which you might not have, the idea was that a practitioner could actually build a care plan with a patient remotely. So you send them a username and a login, they go into the FlindCare website, and they go into their patient version of the Flinders tools, and you've got your version open, and you can both actually be typing into the document at the same time, or it could be just the practitioner, but you're on the phone, you're talking to them by phone, but on the internet, doing their bit, and you're doing your bit, and collaboratively end up with a care plan. And there's a button up on the top right hand corner, it says print. So if you still wanted to use it in an office setting face to face, you could still be sitting next to each other, but doing it on a computer, print off the hard copy and they get a copy. Then it's got built-in text messaging or instant messaging built into it, and a live calendar function. So together you're still saying, okay, so you are going to follow up and see Dr. Kender in his office next Wednesday, and you're going to do this and do that. Bang, 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 it all goes into their calendar. So when they need reminders about visits, it's all in there. And we were talking a lot about what happens after you do a Flinders care plan. What's the follow-up? How do you change the care plan to say this has happened, that's happened? So one of you, or both of you, the patient could be updating it themselves, or the practitioner could be updating it. And then you end up with that, the care plan, and then it becomes, with a patient's agreement, emailed, texted, or sent on to all the other practitioners in the network. In that care, whoever that care team is, everyone gets a copy of the care plan. So that's, that's the future. If the way I was talking there, I was saying, someone's sitting on their computer, their laptop, their iPad, or whatever, accessing the internet, but that part of what we're doing in the next phase is creating a smartphone version of that program. So the person's walking around the shopping centre just about to get another McDonald's, another Big Mac, and Vanessa's email or text message pops up, "How's your diet and exercise going today, Harry?" And he goes, "Oh, fine, thanks. Having a lovely Mac. Wish you were here," you know. So anyway, there's that whole instant sort of way that we can communicate now. It provides massive opportunities, particularly for rural areas, I think, where you can have that communication remotely. Saves them driving, 50 or 100 kilometres to come to your office for a visit, and then you're sick that day and they don't get to see you, and all of that sort of thing. So that's what I see as the next sort of phase that we want to go through. So I'll do as what I say to some people who do the Flinders training. One of the purposes of Flinders training is to teach clinicians to shut up, as in ask open-ended questions and not keep asking or giving the answers. I'll shut up for a couple of minutes. So you want to ask me some questions about the Flinders tools, or just some comments around how they're using them, or what have you? I'm happy to know what's going on. I've heard about some of these amazing complex patients you're seeing.
Very challenging group of patients.
Yeah.
Probably the hardest of the hard, and with the smallest amount of resources to marshal. So everyone here is
doing that on top of their normal job.
Work. Yeah, and is doing this on top of it. Yeah.
Yeah.
I have a question.
Yeah.
I haven't been trained in function.
Okay.
But the way it originally originated in Australia,
Yeah.
it was with a mental health population?
No.
Oh, it wasn't?
No.
Okay.
Ironically, you'd think as a psychiatrist that's probably what would have happened, but it's weird how that we're now using it. But it probably took 10 years to go full cycle back into the mental health population. But it started because the hospital I worked in, or still work in, there was a professor of microbiology who was the head of the National HIV Action Group back in the 1980s when HIV hit the world and was a big disaster. And he had his microbiology hat on, but he also had his kind of health system, how we're going to help improve, reduce HIV, etc. And he had this amazing epiphany that when they got the HIV, which is mainly the gay community, involved in developing their model of care, improving practice, collaborating with the health practitioners, the overall model of care improved and they got better outcomes. So he's walking around thinking, he's had this amazing experience how this improved health, and he had this light bulb moment where if you can do this for people with HIV, why can't you do it with people with chronic diseases? And at that stage HIV wasn't exactly a chronic disease, but it is now. And he found out that I was doing cognitive behavioural type work, with people with anxiety problems and stuff like that, and someone told him a bit about that. So he walked up to me in the corridor and said, "You don't know me, but I'm so-and-so. Someone told me," what did he say? "Someone told me that you can help change people's behaviour and you can measure it." And of course, that's all he said. I just said, "Well, maybe." Where's he coming from here? And he told me that story about the HIV. He said, "I want to set up a coordinated care trial to see if we can do that kind of behaviour change with people with complex chronic physical conditions." So basically I used that model with had an anxiety and depression, but the assessment and the kind of scoring and measurement that patients do themselves, that kind of model of patient rated domains or scores that would then lead to a set of goals. That was the basic common thing. So the whole bunch of people, we designed or devised a care planning method that had some of that in it. But from what the Flinders program is now, that was mainly the problems and goals section. Someone will explain maybe later on, and halfway through the 2-year trial, we got a bunch of the nurses, and other practitioners doing the chronic disease care plan, and asked them what was working, what wasn't working, and we'd had a model where we'd had 8 teams, more or less disease-based: diabetes, cardiac failure, ischemic heart disease, pulmonary disease, and they all designed a care plan based around severity. So high, medium and low severity. If you're in the high, you get 18 hours, medium 12, and low severity would get 6 hours of coordination per year. And it was the most beautiful mathematical model you could imagine. And the idea was that if, depending which category you were in, that was linked to a reduction in hospitalisation, which would then pay for the cost of coordination. And, you know, that would have been a beautiful thing. But at this feedback session, I said, "How's it all going? You know, how are you using the disease the severity system and allocating hours of coordination?" And some nurse bravely said, there's 35 of them sitting in the room. One of them said, "Oh, we don't use that model." And this was a multi-million-dollar national randomised controlled trial. There was 4,500 people in this randomised trial. And there is this woman telling me that they weren't using the actual model that we were designed to be built around in the severity categories. And I was just gobsmacked. And I think, what did she say? And as she was saying it, there were 20 other heads all nodding. And I'm going, "Oh, no, this is not happening. Don't." So I just, in frustration, I said, "So if you don't use that model of severity to allocate coordination, what do you do?" And not with the same nurse or another one, said, we allocate our hours of coordination based on whether someone is a good self-manager or not. And that's where the Flinders program came from. So I'm not answering your question, but there was a mental health group within one of those eight components. There was a mental health group with anxiety, depression, stuff like that. But so then it was such an obvious, true statement. As soon as she said it, I went, "Oh, yeah." So I said, "What do you mean by, can you explain that?" "Oh, my patient's Betty, she's got 5 chronic diseases, she's on 10 medications, home oxygen, she's high severity, but she's a really good self-manager, got a fantastic relationship with a doctor, good team, family supportive, financially okay. She does not need me at all. Whereas Bill, recently diagnosed diabetic, alcohol problems, smoking, overweight, I give all the coordination to him." So, yeah, okay. So the trial management team said, "Can you go away and find a way that you can objectively assess someone's self-management, so we could then decide how to allocate coordination or not." And so it was more about the original idea was about using the idea of concept of self-management and whether you could objectively assess it or not, more as to decide whether someone needed a coordinator. And we hadn't really built or come up with the whole idea that by doing that, which is what you can use the Flinders program to actually decide that as well, but by adding these other parts of assessment, you'd actually come up with a whole added motivational component to the care. So even though we were assessing self-management, we didn't really think at that stage that this was going to provide a huge platform to really empower someone to actually become a better self-manager. We just thought we were just assessing self-management and then going to change the coordination model. So it took a few years before we applied it back into mental health, but I was saying Sharon Lawn, so if you want, anyone who's going to look up some more stuff about Flinders, Lawn, Sharon, she's become one of our main researchers and academics and works in our unit now. But she was a social worker in the mental health service, and was one of the first trials we ever did. And it was targeting people with long-term schizophrenia and psychotic illness and so forth. And she just happened to be part of this trial, and she was working with one particular patient who was the person that what we call a heart sync type person, you know. You see his name come up on your book, and she was going, oh my God, you know. Paranoid schizophrenia, on so many drugs, abusing amphetamines, smoking, overweight, violent, had hit nurses and done all, and had a thing, had to have 2 people visit him at home, and because dangerous. So she said, well, if this program is supposedly going to help self-management, I'll try it out on this guy. And anyway, it made an incredible difference to his life, and she actually wrote that up and published it in the British Medical Journal. And so when people say to us now, oh yeah, these Flinders tools or this Flinders program, looks, you can see where it comes from, this cognitive behavioural, behavioural change, goal setting, very good for people from middle class background who can read and write good English and will be motivated to do these sort of things. I go, no. It can help people who are partially demented, people from Aboriginal and culturally sort of alienated communities and so forth. And it's more about the skill of the practitioner and how they use the tools, rather than the patient group. And the other thing I often get asked is, well, now that you've been working this whole area for 15 or 20 years, you must have worked out a way that you can predict who is going to make behavioural changes and who isn't. And there must be some magic little formula, some way that I could look at somebody and, after meeting them for 5 minutes or getting them to fill out some little form, that I could go, aha, this person will make all these changes and become a better self-manager, and oh no, this one won't. And as far as I'm aware, there's no such thing that exists. And it's because even, that stages of change model, that pre-contemplation, contemplation type model, that some of you would have heard of that. And what people say, oh, this person is a pre-contemplator, they're not ready to make changes yet. That's a pretty traditional model that comes from addictions. And we say, well, as you're about to sit down and talk to somebody, and you know them and think they're not very cooperative, they don't come to a point which they don't care about their health, pre-contemplator, and then you sit down and start going through the Flinders tools, and that exactly the person you think is going to be completely a waste of time, somewhere during that interview they go, well, if you really want to know about why I'm smoking, and what I really want to do about my life is such and such and such and such, you're just blown away. Then where did that come from? Whereas there'll be this nice middle-class, well-educated woman that sees, has got a lovely social network, and she wants to make a few behavioural changes, and you go through the Flinders care planning stuff, and she goes, yeah, I'm going to do this. And 3 months later, she hasn't done a thing. And, so we don't, so I sort of say, my approach is to say, give every single person the benefit of the doubt. Don't have a preconceived idea of whether they're going to make changes or not. And you might go through the Flinders tools with somebody, and you'd sort of get a feeling by the end of it like, oh, the person was just going along with it, didn't really want to make that many changes. But then you basically just keep in touch with them, keep talking about their goals, keep finding out what that's going on, and be positive. And for all sorts of weird reasons, 1 month, 3 months, 6 months later, that person comes back and says, when you asked me about that problem statement, about so-and-so, and I wrote down that such and such, that really wasn't my problem. What it really was so-and-so and so-and-so. And they've just been stewing things over in their head, and then they had a conversation with their Uncle Barry about something, and it's gone boom. But what they've realised is that you've got a particular approach, an open-minded approach, and you're being positive. You keep in touch with them every now and then. It takes you 5 minutes on a phone call. So when they are ready, they'll come back at you. And you've written them off, you think, oh, I'm actually done. The reason I'm saying that is when we did that coordinated care trial, one of the nurses who was learning this approach, in fact, I reckon it was the first or second patient she ever saw, and he had chronic obstructive pulmonary disease, and he was sort of right towards the end of that. He wasn't really going to have that long to live. And when it came to the main problem and the main goal, he said, I haven't really got a problem, I just want to be left alone to die. So, and she kept trying to come out with something positive. And he said, no, I haven't got any other goals, I just want to die. Be left alone to die, you know, get the message. And she, because it's a clinical trial, she said, oh, I've got to do something. So he said, no, that's okay. Just write it down on his care plan. But just ring him up once a month and just see how he's going. And I think it was around about the 4th or the 5th month. He said, you know, she was just about to put the phone down, and he said, hang on a minute, I keep thinking about all that stuff you've been talking about. And if you really want to know what I'd like to do, is I'd like to be able to get back to going down to the local pub, see the old friends I used to mix with, and play darts. And they did it. So the next 2 to 3 months, I mean, and that meant that he actually had to better manage his physical health better. He had to cut down on his smoking, and he had to do...
one arm, yeah,
Yeah. And he made this, you know, it's not a dramatic recovery, but his actual quality of life changed, and the whole, you know, pattern of his care changed and the rest of it. So it was actually a very small amount of time that she was spending just to keep in touch with him and just find out what was happening. So it was a huge, and there's been many, many stories like that about people. And I say, well, I think this program's not a miraculous cure for all these people who are disengaged, miserable, unmotivated. But if it helps 50% of those people, that's all right. You know, if you say just the people that are really unmotivated, uncooperative, all that kind of thing, and it worked, it really improved things for half of those people, that's an incredible step forward. And so I never for 1 minute say the Flinders program is the only incredibly mysterious, wonderful thing that's ever going to change the world. But if it can bring the clinicians and the patients closer together, and you have this partnership approach in being who's responsible for their health, then you've got to make a lot more steps forward than not. So there is. I mean, there's quite a paradigm shift, isn't it? The way you. Actually, I was telling a story about one of the family physicians who actually lives in the magnificent Barossa Valley, which is a famous wine growing area. So if any of you ever come to South Australia, we'll take you straight to the Barossa Valley. Was saying, you know, she's been using the Flinders tools herself. She has got a nurse that does some of it. And she's saying the thing that I like about it is, you know, I've had these difficult, let's be truthful, it's what she would have said, I've got some difficult patients who don't want to make any changes to their lifestyle, and I get really, really frustrated. And I'm, you know, felt powerless. But I actually felt it's my responsibility to fix up their problems like their smoking, because I can see they're going to be killing themselves, you know. So what the Flinders tools did for me was it actually shared the responsibility between me and that client, the patient. And it lifted this whole sense of stress off my shoulders, and I feel like now we are sharing the problem more. And we're jointly responsible for the outcomes. And the way I actually encourage physicians or nurses or other practitioners to say, when you're developing the care plan, and you've got to their main goal, and you're starting to get to the goals on the actual care plan itself, and you say who's responsible, and the patient's name's there, and sometimes your name should be there as well, which is okay. And then you say, so now we are going to see each other again in 1 week or 2 weeks, and I'm going to ask you, did you do the things you said? And I want you to ask me, did I do the things that I said that I was going to do? And you know, for most patients, that's a complete shock. You know, you mean you want me to ask you whether you actually followed on and did some of that stuff? So the sharing is both ways. So you're both accountable and responsible. So you're sharing the responsibility and you're sharing the stress, but you're also sharing the success. So as soon as that patient makes that one extra bit of gain, I mean, you actually feel fantastic, don't you? And there's this real kind of like, oh, I mean, they did 90% of the work, but you were part of it. So I think if that's what changes the way that we can work together, it improves our quality of life as well as the patients. And I've said to practitioners, I reckon it's quite legitimate to say to a patient, we've now identified your priority, which might not be a health priority, but actually my priority, because I'm a physician, because I'm a nurse, because I'm a social worker, my priority is to help you with these things, and I'm actually feeling, I wouldn't necessarily say a bit of a failure, but I said I actually really worry about the fact that you're not able to do this stuff. And it'd be really good if you help me to feel better about the changes you're making. And you can only say that if it's true, you know, if you're being honest about it. Because in other words, you're sort of self-disclosing a bit that you are really worried about this person's behaviour, activities, whatever it is. And what we've found is that the patients just absolutely love the fact that you're being honest. But it's a complete shock to them. A lot of them, they kind of know that you care about them. You know, most people know that you care about them. But there's this thing about like, oh, I actually worry about these things that you do. And then what you're doing is you're eliciting a helping behaviour from someone else. So, in other words, you don't say this explicitly. Even if you don't want to help yourself, you can help me. You can help me feel better. Now you might say, well, that's being a bit manipulative, but I mean, it's pretty open. It's pretty open and honest, you know, you're sharing that kind of thing together. And you wouldn't do it you wouldn't say that if you thought it was, you know, unfair to the patient. But I was saying there was an example of that in one of the trainings that we did with a doctor doing this Flinders program with an Aboriginal patient. And when she said, if I help you with your daughter's housing, will you help me work with you on your diet and exercise, because he's a very large, obese man, and he refused to talk about his diet and exercise up until that point. And she said, would you help me do that? And he looked and he put his finger and says, you've got a deal. And that's what the deal is. I'll help you with your problem, and together we'll work to go on another problem, which at the moment isn't your number one priority, but later on I'd like to work on. Okay, that's a contract between you and me. So that's how it works. Do you want to talk about some of those things we discussed today? We could have some of those questions you had about the follow-up on the care plan.
Yes, I would. I had one patient that we developed a goal together, and she had identified a problem of a daughter who was having problems, and she would call this patient repeatedly, and it would take away her appetite. She wouldn't eat healthy, and it would stress her out. And she's one of our high utilizer of emergency room services, and that's what she's identified, chosen.
Wait up for a quick picture. I don't want to.
And so,
Yeah, okay.
Dr. Goldwash and Dr. Pender, Vanessa, Andrew.
identified this problem with the daughter contacting her regarding serious problems, drug and alcohol issues, and the goal she identified was to sit down, eat an uninterrupted meal, and I think it was every day, but it might have been 3 days a week, I forget exactly what it was, and then we had some additional things to try to target the health conditions of obesity, back pain, smoking, diet. And when she came back to see me, by the time she came back to see me, it was no longer a problem for her. Health part really we didn't make much progress there. But she said to me, well, I don't have, I said, well, you know, and I didn't, actually I was kind of stuck right then when she said it was no longer a problem for her too. I was like, well, now what do I do? And she couldn't identify a new problem either. So that was that one individual.
So there were two aspects of that. Like, there was the one about, you know how we've always, the challenge is often to get that goal, the main goal, right. And that particular goal sounded like it was fairly short term. And I was saying, because that was the main goal written on the top of the form. And, you know, as in, stop answering the phone from my daughter if she rings during meal times.
Thank you very much.
Thank you.
Thank you, actually.
Nice to
Thanks
meet
for
you.
coming, yeah.
Thanks.
And I was saying how that's probably something that could be achieved within a week, you know, pretty easily. Whereas if you'd said, if you're able to manage your daughter's contacts and spend more time doing the things you wanted to, what would you be doing in 6 to 9 months' time? And so it could be something like, you know, spending more time with my husband, going to the movies, or whatever, you know. So in that case, that goal could have still been relevant. And that statement about not answering my daughter's phone calls during meal times could have actually been on the care plan itself, and as a new item. So you can add on items on the care plan that don't directly come from the cure and response interview, if it relates to the main problem, the main goal. So this is a little step. So it works exactly the same way, because you have what's the issue, what's the goal you want to achieve, which is spend more time with my husband. No, anyway, so whatever the aim was you have written down. Steps to get there would be not answer the phone when my daughter rings at meal times, etc., etc. So it fits beautifully on the main part of the care plan, and then something like a week later, done. So then you're still going back to saying the main goal. Well, so are you able now to achieve that main goal? Now, if that's the case, and it's within a month or two, then you would need to make a whole new problem goal statement. But so it just depended. So that was the first point. The second one that you asked was that old one where someone, even though they might have some chronic diseases or conditions, actually doesn't have a real problem. They might be managing everything pretty well. They're what we might call as a really good self-manager. And it's quite okay to have no problem identified, but you can have a maintenance goal. So, now obviously these sort of people you're not going to spend much time on because they're already a good self-manager. But later on it might be relevant. So I was giving examples of the maintenance goals. Something that you are currently doing more or less regularly, that's a sign that you are well. That if it became interrupted would indicate that you're not managing as well. So it could be, playing golf 3 times a week with my pals, or it could be, doing yoga or going to visit my auntie, or anything that you currently do on a regular basis. So 6 months later they're visiting the family physician, they're visiting so-and-so, and they look up, and the person looks on the problem statement, the goal statement, and just says, oh, you're still visiting your auntie 3 times a week to do so-and-so? Yep, beautiful. So that's more or less the end of the conversation. So you've identified a maintenance goal, it's okay. So some people get stuck feeling that they have to come up with a problem statement, even when the person's basically, no, I'm fine. And I mean, we feel a bit guilty about some of the practitioners must be, really, come on. There's got to be a problem somewhere,
That's probably more likely to happen in my practice
That's right.
in rural health, though.
Yeah.
There's always a problem.
There's always a problem.
In rural health. That'll never come up in this population, probably.
So come on.
They're just pretty, okay, which one of these 3 major problems should I choose from? But yeah, that comes up in my practice,
Okay.
when I'll do things.
I was kind of reassured once I read some something in the newspaper about some research into ageing. You know, because everyone's worried about ageing and everyone's getting sicker and all that. So they said, oh no, it was an Australian thing. It said something like, 50% of people over the age of 80 are the happiest, most comfortable they've ever been in their lives and haven't got any problems. Or you know what I mean? They might have some chronic diseases, but I thought, oh yeah, okay, that makes sense, And I was thinking about some older people I know, they've got a bit of arthritis or a bit of this, that stuff, but no, they haven't got any financial worries, they're sort of okay.
I learn a lot from patients like that of mine.
Yeah, that's right.
You're doing things really well and you're happy and, you're retired and you're older and you're still healthy, so
Yeah.
tell me your secrets, You learn things, it's good.
Yeah.
And then, in the setting we're working in, major challenges, major medical issues, and fertile ground for the program.
Well, the other general aspect, the example you were giving was people with schizophrenia about quit smoking and how difficult it is, to work with that group of people, and often who might feel that cigarette smoking is one of the only pleasures they've got, or that kind of thing. But there's been a couple of big programs or studies around people with long-term mental illness and smoking, and some of those programs have actually been very successful, but it's pretty well only when you've got a whole system that's behind it. So you have an inpatient unit, you have a community team, you have the other services in the community, and you've almost got to have a community-wide program as we're going to help people with long-term mental illnesses quit smoking. And there's so many different bits of it you have to think about. Where is that going to happen? Who's going to support it? And the classic thing that sabotages those programs is that it might be a mental health practitioner, a nurse or a social worker or someone else, but it could be the GP. And if they're not aware that everyone's working on this whole program, there's so many, and I'm probably guilty of it myself, the patient might say, oh, I've been trying to quit smoking, but I find it really difficult. And they don't tell you that they're part of some whole program that's trying to do that, but they say that. And the practitioners just almost automatically say, oh, look, that's the least of your priorities. You need to look after your schizophrenia. That's really good as long as you can stay out of hospital. And within just one little comment like that, you just go, yeah. So that's why I meant there's a bit of a team approach. But we have like a national quit.
Sorry to keep that